Good afternoon and welcome to our Congressional briefing on the report, The State of Obesity 2020, Better Policies for a Healthier America, hosted by Trust for America's Health, or TIFA for short. My name is Tim Hughes, the External Relations and Outreach Manager at TIFA. We would like to thank our speakers and audience for being with us today. For today's webinar, audio is through your computer speakers or headphones. Real-time captioning is provided today by Janie Conco of ACS Captions. For captions, click on the multimedia viewer icon under the circle with 3 dots at the bottom of your screen. Next, on the right side of your screen, locate the link in the captioning panel that says Show Hide Header. In the captioning window, if the captioning window ever disappears, click the multimedia viewer icon to bring it back. We encourage you all to share your thoughts and questions about today's presentation by typing them in the Q&A box. We'll try to answer as many questions as we can as time permits. To open the Q&A box panel, click the circle with the 3 dots at the bottom of your screen. From there, select all panelists in the drop-down menu so that your question will get sent to the correct location and press enter. Before we start today's discussion, we would like to bring up on your screens a poll question to get a sense of what sectors are joining us today. And so I will bring this poll question up. And so what sector/industry best represents your organization? Please click all that apply. The choices are advocacy, community-based, congressional office, government, non-congressional office, healthcare, media, nonprofit, public health, other. Please submit those responses, and while we wait for your answers, it is my pleasure to now introduce our moderator. So our moderator for today's event is Dara Alpert-Lieberman. Dara is TIFA's Director of Government Relations, where she oversees the development and implementation of federal government relations strategies and works to advance and ensure implementation of TIFA's policy priorities. I will now close the poll and let's bring Dara on. Welcome, Dara.
Thank you, Tim, and thank you everyone for joining us today for this important discussion. I'm not seeing poll results yet. It looks like there's some time left, but I know people are still joining. Anyway, welcome. I'm Dara Lieberman. I'm the Director of Government Relations for Trust for America's Health. And first, I just want to welcome you all and thank you to our esteemed panelists for taking the time out of their busy schedules to join us today. First, I will be presenting the results of our annual report, the Ready or Not report. I'm sorry, the State of Obesity report. And then I will be going through our panelists today. And now I'm starting to see the results. It looks like we have quite a few participants from public health, from the nonprofit sector, and from governmental and congressional offices as well. And it's good to see community-based and advocacy organizations represented. So there's a nice cross-section here of people interested in this issue. After our presentations, as Tim said, we'll have time for discussion and questions from the audience. So I would like to recap our annual State of Obesity report, which we jointly released with the Robert Wood Johnson Foundation. A copy of the full report is at tifa.org, and we can include a link in the chat as well. My hope for the briefing is that you'll leave understanding the latest data and trends in obesity in the country and walk away with concrete examples of how we can work together to address the epidemic. And to be clear, this is an epidemic. As you'll see from the slide, obesity rates are still climbing. And sadly, 2019, which is the year that our report data is from, is the first year where national obesity rates passed the 40% mark. This is adult obesity rate. So it was around 42.4%. Not only are we at a record high, but we've reached that level at a very quick pace. So by comparison, in the year 2000, West Virginia was the highest level of adult obesity at around 23.9%. And in 2019, Colorado was the least obese state with a rate of 23.8%. So in just 20 years, the ceiling has become the floor. So now the state with the least obesity matches the state with the most obesity from 20 years ago. Next slide. And we also know that obesity levels vary substantially by race and ethnicity, as well as by education, income level, urban or rural population. And Dr. Blank will be speaking more about this in a moment. But obesity rates do depend on numerous factors, and we see that there are persistent inequities in racial and ethnic groups with high obesity rates. We talk about this a lot in this year's report and last year's report because many of these disparities are due to deep-seated equity issues like multi-generational poverty, like a lack of access to food, nutritious food and physical activity, rather than biological differences. Next slide. Like adults, the number of children with obesity also sadly continues to rise. In 2018, 19.3% of children aged 2 to 19 had obesity, which is the highest rate ever. And childhood obesity is just incredibly important because preventing obesity is so much easier and more effective than trying to reverse the trend later on. So that's why you'll see so many policies and programs focused on the school and preschool level. We also need to focus on the first 1,000 days because it's critical to encourage healthy nutrition habits through breastfeeding and through encouraging age-appropriate diet patterns. Next slide. Dr. Blank will be speaking a little bit more about the health consequences of obesity, of which there are many, but we also know that there's economic and national security consequences as well. For example, the excess medical costs that are tied to obesity is around $149 billion per year, and Medicare and Medicaid pay for about half of those preventable medical costs. And with the baby boomers continuing to age, that will add to Medicare's costs as well. Next slide. This year has really exposed the overlapping crises of chronic disease, of health inequity, and of COVID-19. And it's something I think many of us in public health feared for quite a while, that would put America at a national security risk because of our high rates of chronic disease. The CDC data from early in the pandemic shows that almost half of hospitalized COVID-19 patients, adults with known health histories, also had obesity. And the chronic conditions that are associated with obesity also put people at higher risk for from COVID outcomes. And at the same time, the COVID-related recession and the closures have also caused low-income households to be more likely to have food insecurity, which raises their risk of obesity. And it's made it even more difficult for people to have access to physical activity and healthy eating. For example, gym closures, reduced food purchasing power due to the economic recession, and the interruption of school meal programs for many. And I think it's something we all continue to fear as the holidays near. Next slide. So despite the severe human and economic toll associated with obesity and the fact that these rates are rising, public health and prevention funding remains inadequate to face this crisis. Overall, we spend about $3.5 trillion annually on healthcare in the United States, but public health and prevention represent just about 2.5% of all healthcare spending in the United States. And as you can see from this graph, which is from our annual chronic underfunding of public health report, CDC's overall budget, when you account for inflation, has remained about flat for the past 10 years. And any little increases that we've seen here and there are often due to one-time funding. So it's really not adequate for the scope of the problem that we're trying to tackle, both within CDC and nationwide. And as an example, CDC's FY20 fiscal year 20 budget for the Division of Nutrition, Physical Activity, and Obesity is about $57 million per year, or roughly 17 cents a person in the United States. So we keep asking CDC and public health to do more, but not giving them the resources to do it. Next slide, please. This year's State of Obesity report had a very timely section on food insecurity, where we talk about how food insecurity is a key social determinant for obesity and give an overview of several programs that work to reduce food insecurity. The prevalence of food insecurity, unsurprisingly, is linked to economic conditions at the individual and the societal level. So low-income households are much more likely to be food insecure compared to the overall population. And 2020 is really projected to be a record-breaking year for food insecurity, of course, due to the pandemic and the related economic recession. With more than 20 million Americans losing jobs just in the spring, many jobs with reduced hours and incomes, it's forced societal changes that have increased food insecurity, some of which I talked about, like lack of food availability in schools and purchasing power of healthy foods. We focused on food insecurity also because there are strong associations between food insecurity and obesity, particularly among children and women. One study showed that adults who were food insecure had a 32% greater chance of having obesity compared to food secure adults. And there are several mechanisms for how this might lead to obesity. So one is the inadequate food affordability makes it harder to access a healthy diet. It's possible that higher levels of stress and anxiety from food insecurity generate higher levels of stress hormones, which heighten your appetite. And there is a physiological response to lack of food availability, which causes your body to store higher fat amounts. So we think it's really crucial to further study the complexity of the relationship between food insecurity and obesity, and to really try to address those dual crises as well. Next slide. In the report, we highlight two great examples of federal programs that are actually improving both food insecurity and improving food security and reducing obesity rates. So first is changes to the WIC food program in 2009 have contributed to a decrease in obesity among participating toddlers, which is good news and sort of an example for how we can leverage existing programs to make children healthier or to give them better opportunities for health. And then secondly, there were new nutrition standards for the school foods programs in 2012 that have significantly improved nutrition quality. And Dr. Bleich will be speaking more in depth about those programs in her presentation. Next slide. Now, clearly more needs to be done. One of the key aspects of all TIFA reports is our policy recommendations. And these are some of the overarching themes from this year's report recommendations. One is, of course, prevention is key. It's easier to prevent in children than reverse trends later on. Progress requires funding evidence-based strategies adequately in order to bring them to scale. And funding must be conducive to comprehensive long-term approaches that promote healthy eating and physical activity. These approaches should cross sectors and federal agencies and state and local agencies as well. Unfortunately, there is no silver bullet that just one recommendation will solve the obesity crisis. It's imperative that we focus on populations that bear a disproportionate burden of obesity first. And these last 2 points are especially important because obesity is a chronic disease, but it's also symptomatic and responsive to broader equity issues like poverty and institutional racism. Next slide. And I'll go into a little bit more depth on some of our policy recommendations, but we do have 30 recommendations in the report, so I encourage you to take a look and explore those. And we divide them by the stakeholder, the federal, state, or local stakeholders that can leverage those recommendations. The first area where we think we can make a big difference is ensuring that we reduce obesity-related disparities by expanding and investing in the programs that we know work. So we do recommend expanding funding for the state physical activity and nutrition grant, which comes out of CDC. And as an example, where you saw the map of where obesity is in the United States, is everywhere. And unfortunately, CDC only has enough funding from Congress to support 16 states through the SPAN program. Similarly, we recommend expanding the REACH program, Racial and Ethnic Approaches to Community Health, and you'll learn more about these from Dr. Blank and Ms. Gonzalez as well. Additionally, Congress, we think that it's long past time to fund CDC and public health to engage more fully in social determinants work, which are the non-medical factors that impact people's health. So we want to empower public health to work with other sectors to address the upstream issues that contribute to a community's health status. One example is the Improving Social Determinants of Health Act of 2020 that would create such a program at CDC. Secondly, we talk about decreasing food insecurity while improving nutritional quality, which is especially important during the pandemic. So we need to work with Congress to strengthen essential supports for low-income individuals through programs like SNAP and WIC. So we have some specific recommendations in the report around those, like ensuring that child nutrition reauthorization occurs and updating the dietary guidelines, making sure those are evidence-based. And we support increasing WIC eligibility to age 6 and increasing the SNAP benefit values, especially during national public emergencies. And we need to continue the waivers that have happened in those programs during COVID-19. The third recommendation here is on changing marketing and pricing strategies that are contributing to health disparities. We believe Congress should close tax loopholes to end unhealthy marketing to kids, especially because TV advertising for unhealthy snacks and drinks disproportionately targets children of color. Next slide. The fourth area is ensuring physical activity opportunities in the built environment are safer and more accessible for all. Groups and governmental agencies should be working together to increase opportunities for safe physical activities, like boosting funding for active transportation and complete streets, pedestrian and biking infrastructure, safe routes to schools. Those programs that contribute to our built environment that give the opportunity for physical activity that not all neighborhoods have right now. And we need to support physical education through education funding and increase flexibility during COVID so that kids are continuing to be physically active even if they're distance learning right now. And lastly, ensuring that public health and healthcare efforts are complementary. So it's impossible to really talk about tackling the crisis without also mentioning health insurance coverage. So millions of Americans still do lack adequate health insurance coverage, and of course, there are disparities by race, by sex, by age, and these have been exacerbated by the pandemic, where as of May, about 27 million Americans were thought to have lost their employer-sponsored insurance. So Congress needs to extend protections for that as well. And Congress should encourage health insurance coverage of evidence-based programs in multiple ways. So one example is enforcing the U.S. Preventive Services Task Force management recommendations for behavioral counseling, and encouraging Medicaid programs to cover evidence-based pediatric weight management programs as well. So there's more details about all of those in our report. Next slide. And here is where you can find the full report and the contact information for my colleague Daphne Delgado, who you'll hear from later today to help moderate the Q&A. She is our advocacy lead on chronic disease and obesity prevention. Next slide. So we will save questions for the end, but just a reminder to submit your questions into the Q&A panel, not the chat, and we will try to get to as many of those questions as we can. We will send complete biographies for our speakers after the meeting today, but so I'll briefly introduce them now. I'm pleased to be joined on the panel by Captain Heidi Blank, who is the Chief of the Obesity Prevention and Control Branch at CDC. And as the branch chief, she oversees CDC's monitoring of state obesity prevalence and key nutrition and physical activity, behavioral and system supports to help ensure all have a fair chance at health. Next, we'll hear from Nora Gonzalez, who is the lead community health worker for the City of San Antonio, the Metropolitan Health Department's Healthy Neighborhoods program. As part of her great work, we'll hear about how she's worked on the Healthy Corner Store initiative to improve access to fresh fruits and vegetables for areas of high need, Pecan Valley Teaching Garden, and the construction of inclusive playground where all children can play together, regardless of ability. And finally, we will hear from Dr. Sarah Bleich, the professor of public health policy at Harvard's T.H. Chan School of Public Health. Her research provides evidence to support policies to prevent obesity and diet-related diseases, particularly among populations at higher risk. Previously, Dr. Bleich was a senior policy advisor to the U.S. Department of Agriculture and former First Lady Michelle Obama's Let's Move initiative. Both Dr. Bleich and Captain Blank are members of the National Academy's Roundtable on Obesity Solutions. Next slide. All right, welcome, Dr. Blank.
Good afternoon and good morning, everyone. Thank you to the organizers for having me today to be able to share our information. Next slide. Next slide. In this first slide, I want to share data from our nation's youngest children. These are our future teachers, farmers, leaders, and innovators. As Dara shared, we have a high amount of obesity in the United States. This data shows information we have for children aged 2 to 4 years in our WIC program. And the good news, as we've seen, is we've seen decreases in the prevalence of obesity since about 2010, but the magnitude is still high. We have 13.9% of America's 2 to 4-year-olds in the WIC program with obesity. And we have disparities. As the data shows here, we have high prevalence among certain race ethnic groups, including American Indians, Alaska Natives, and Hispanic children. This 13.9% translates so that in any typical pre-K classroom in America, 3 of the children already have obesity. This puts them at risk for future bullying, poor health, and other consequences. Next slide. The CDC has recently published our data on adult obesity. This slide shows where we were in 2011. And over time, as Dara showed, we've seen an increase in obesity through the 2019 data. Looking at our most recent prevalence data, we can see in 2019 that we now have 12 states that have an obesity prevalence at or above 35%. This is up from 9 states in 2018. Again, we're seeing that 1 in 3 adults in our states have this high level of obesity. Next slide. Similar to the disparities that I mentioned from our youngest children, we see a similar pattern among adults in America. Combining self-reported adult obesity data from 2017 to 2019 in our behavioral risk factor surveillance system, we can see that we have 6 states on the left with an obesity prevalence of 35% or more among non-Hispanic white adults. As we move to the middle slide, we see we have 15 states having an obesity prevalence of 35% or higher among Hispanic adults. And in the farthest right, 34 states in the District of Columbia having an obesity prevalence of 35% or higher. This data very much dramatizes the need to address key risk factors for obesity, including drivers such as nutrition, physical activity, but also social determinants of health, including poverty, education, and housing. Next slide. I've shown you the national data, but I want us to think a little bit more about obesity, thinking about our friends, our family, our colleagues, and our neighbors. In our own lives, we probably know someone struggling with their weight or struggling with diabetes or cancer. Since 4 in 10 adults have obesity and 1 in 5 kids have it already, we really need to think about what are the policies and programs that can help them. But we also need a better understanding of obesity. Obesity is defined using body mass index, or BMI, and it's a screening measure of obesity. It's defined by kilograms of weight divided by height as meters squared. So having a BMI of 30 is considered to have high adiposity or obesity among adults. But obesity is not just this number. It's a highly complex condition with many phenotypes. And it's driven by our genes and biology interacting with society and environment. Recent data shows up to 80 genes are involved with issues such as metabolism, satiety, energy use. And this very much interacts with our daily lives. It interacts with our food intake and eating behaviors, our beverage consumption, such as sugary drinks and alcohol, our inactive lifestyles, including sedentary activities. We also have different life stages. We have issues such as our pregnancies, issues with sleep, adverse childhood experiences, how we deal with stress, as well as other aspects of behavior, including our exposure to environmental chemicals and certain medications that being more likely to cause increased adiposity, such as steroid hormones and some antidepressants. So as you can see, it's a very complex disease. Next slide. The other thing we've learned in the last 20 or 30 years is that adiposity or obesity is a very metabolically active condition. So adipose tissue is an active endocrine tissue, and it leads to an increase in cells called adipocytes, which release adipocytokines. And these actually lead the body to have a low-grade chronic inflammation. This chronic inflammation actually can impair our immune function. And this is really important long-term for the diseases we're going to talk about, but it's also important in the time of COVID-19 because we know that really having a well-balanced diet and a good immune system is really the best first defense at being able to ensure that we can fight off other types of infections. We also know that diets lacking in important nutrients can impair our immunity. There's a list here, but includes vitamins C, D, folate, zinc, iron, and certain proteins have a role in immune health. And unfortunately, our Western diets that are high in refined sugars, grains, and meats can actually change our gut microbes, resulting in chronic inflammation and actually suppressing our immunity. But we know our more research evolves keeps showing us that there are foods that can help moderate the inflammatory response, and this can help our immune system to be more effective at fighting an infection and other challenges to the body. So now more than ever, it's important for good nutrition and physical activity. Next slide. The health risk that obesity causes increases a person's risk of several acute and chronic conditions, as well as a person's risk of all causes of death. Obesity contributes to many of the leading causes of death shown here, including heart disease, approximately 13 cancers, strokes, type 2 diabetes, as well as conditions involved in mental health. Next slide. We also know from the work of researchers across the United States and the globe since March that adults of any age with underlying medical conditions are at increased risk for severe illness from COVID-19. Many of them are listed here, including cancer, type 2 diabetes, heart conditions, immunocompromised states, including those folks from cancer, but also obesity. So we know obesity at 30, as well as severe obesity, are increased risk for severe illness from COVID. Next slide. So as we've mentioned here, we know obesity can impair our immune function. It increases our risk of severe illness from COVID. People with obesity have up to triple the risk of hospitalization due to a COVID-19 infection. Mechanisms are varied, but include decreased lung capacity and lung reserve, which can make ventilation more difficult. And unfortunately, as BMI increases, the risk of death from COVID-19 increases. And as we've shown you with the disparities in obesity, Hispanic and non-Hispanic Black adults having a higher prevalence, they're also more likely to suffer worse outcomes from COVID-19. Next slide. But there is good news, and as we've shown a little bit from the Healthy Hunger-Free Kids Act and from WIC package changes, we know that there are protective individual factors and community factors. So we know that the best start for children includes breastfeeding, having a healthy diet pattern, regular physical activity, limiting screen time, getting optimal sleep, and finding ways to manage and limit stress. Next week, many of us are going to be thinking about this as we put together our Thanksgiving dinners. We can be thinking about how can we add in healthy foods such as kale and collard greens and spinach. How can we be thinking about having more sweet potatoes? So we have an opportunity, all of us, next week as we think about how we're going to Zoom with family across America. Maybe we're going to take a walk after that Thanksgiving meal and reach out to our family. We all have this opportunity to make a difference in our lives. But unfortunately, many folks face high barriers to try to have these healthy lifestyles. So we need protective community factors for all. This includes supporting new parents for breastfeeding and infant feeding, including hospital and peer support, ensuring everyone has convenient access to affordable, healthy, accessible food and beverages, including drinking water, in childcare, schools, and communities, having safe places for physical activity, and again, quality health care, being able to screen, counsel, have lifestyle program opportunities, as well as therapeutics. Next slide. So the 5 actions our division supports within states and communities to address obesity includes, again, thinking about land use policies and ways to make physical activity accessible for all, thinking about areas like food service guidelines and food bank standards to make healthy food choices available, supporting our states and our hospitals to make breastfeeding easier to start and sustain, working on our 0 to 5 standards. This includes work in our early care and education setting. This includes regulations and quality rating improvement systems, ways that we can help our children have the best start. And again, for the 14% of children, the 19% of children that have obesity, really supporting them on self-management through family lifestyle programs, ways to work with parents and our children for healthy growth. Next slide. In DNPAO, our Division of Nutrition, Physical Activity, and Obesity, we have a number of programs that help support our states and communities. This really layers on here during the pandemic, where we know we've had a number of federal programs and waivers really step in and try to help ensure that we have food insecurity access. But as a backdrop, we do have our 16 states in our SPAN, our State Physical Activity and Nutrition Program, working to strengthen the areas I've talked about. We have a high obesity program that leverages community extension services, really reaching many folks in the rural communities to help them with healthy food access and opportunities for physical activity. And then our REACH program, which I'm going to talk a little bit more about. Next slide. So the Racial and Ethnic Approaches to Community Health, or our REACH program, is 21 years old. This is one of the few CDC programs that explicitly focuses on improving chronic diseases for specific racial and ethnic groups across many types of communities, including urban, rural, and tribal communities. We have over 36 recipients or organizations across the country that work with local coalitions to culturally tailor interventions to address preventable risk behaviors. Next slide. These behaviors and our strategies include, again, working on healthy nutrition, physical activity, and tobacco-free living. We also work in community clinical linkages, really trying to ensure areas like FQHCs or federally qualified health centers screen individuals for issues like food insecurity or health problems, and really ensure that there's resources within the community to address their needs. Next slide. But one of the great things about the REACH program is through their trusted partners, through their trusted stakeholders, and really having community voice, is that they've been able to pivot during the response of COVID-19. The work that we've been doing in these areas has really helped March through November here to make sure that those at the highest risk of COVID and at the highest risk of chronic disease have been able to have their needs met. These are examples. For example, in nutrition, we've been able to redirect to get fruits and vegetables to families in need, using innovative, safe, physically distant, healthy food delivery models, or accelerating food delivery at competitive pricing to local markets. In breastfeeding, the use of telehealth has been able to really ensure postpartum lactation consults and support new moms. Baby cafes have moved to virtual and online to ensure that new moms are having the support they need. Social media video services are able to really provide quick tips to families around breastfeeding in those first few days and as breastfeeding continues, and really ensuring the training activities for the workforce that supports breastfeeding are able to move into virtual settings. As we thought about trying to get our physical activity during the pandemic, we really need to make sure that everyone has good options, including opening streets for slow, safe access and improving park access. As we ask individuals to move outside carefully and slowly with masks and social distancing, having a local park to walk to is very important. Next slide. Other innovations that we've seen our recipients take on include our high obesity program, where in the Mississippi Delta region we saw increased levels of food insecurity, and the local change group really stepping in to help communities, launching food pantries in one of the counties, and in two other counties expanding storage capacity at their food pantries to meet the food needs of local residents. In our early care and education setting, we've seen an amazing opportunity for professionals to take on issues related to the social safety net of feeding children, but also move many of their trainings to virtual and online platforms. As childcare has had to navigate a challenging time, many of the professionals have been able to meet with stakeholders. So, for example, in one of our states, we were able to match 15 farm groups with early care and education providers. And so during this time of lowered classes, really supporting local food procurement as part of one of the strategies to address food needs. We also have a number of professional development opportunities that have moved online. This really helps support our professionals who are often stretched thin during the regular type of the year. But Arizona is an example that has created online training materials with their Head Starts and pre-Ks. We're able to get valuable feedback during this time. Alabama, as an example, just launched reimbursement for local foods in their ECE settings. So again, we're just seeing how these trusted partners and programs are able to navigate through the time of COVID. Next slide. Finally, we have a new program, Building Resilient Inclusive Communities, or BRIC. This program has been funded with CARES and COVID-19 funding, and it really has an ability to think about three areas: nutrition security, access to safe physical activity, and social connectedness. So this program will be put out to include a number of SPAN states as well as unfunded states that we call ambassador states. We're working through the National Association of Chronic Disease Directors. States will be working with their local communities to provide grants to meet unique population needs. We're very excited about this program. We really think here in 2021, as we're trying to reduce the chronic disease burden and make sure that from an acute perspective are meeting nutrition security needs, that we have the ability to really build sustainable programming in the states, focusing on those populations at the highest risk. And stay tuned at CDC as more communities will be selected, and those will be notified, and we'll be able to show this to the public in early 2021. Next slide. Thank you again, and if you have any questions, please enter them into the chat. Thank you.
Thank you so much, Dr. Blank. And for our audience, in case there was something you missed, the slides will be sent out after the briefing. So in case your furious note-taking is not adequate. And just remember to submit questions into the Q&A. We'll try to get to some of those after the presentation. And now I'm very pleased to turn it over to Nora Gonzalez, who is with a community health worker in the City of San Antonio Metropolitan Health District. Ms. Gonzalez?
Good afternoon, everyone. Can everyone hear me? I'm really excited for this opportunity to be here with you all today, just to share a little bit of a perspective of the groundwork that's happening here in the City of San Antonio with our Healthy Neighborhoods program, all because of the CDC REACH grant. As we continue to navigate this new normal during a global pandemic, it has become crystal clear to us now more than ever that the work of public health cannot take a break, and we must continue to move forward. So I sincerely hope that with my words today, I can help paint a picture in your mind to show the incredible groundwork that is being done by our team to improve the health of our most vulnerable populations. Two of the projects that I will share with you today are the Healthy Corner Store Initiative, a project that provides corner store owners in the neighborhoods that lack access to healthy foods with the support to sell fresh fruits and vegetables. And also the Pecan Valley, you don't have to move the slides yet. I'll let you know when it's time. Thank you. And also the Pecan Valley Teaching Garden, a project that introduces basic gardening skills and hands-on nutrition education to WIC participants and residents in the surrounding neighborhoods. Both of these projects are geared towards improving the health of the residents in the near south, east, and west sides of San Antonio, where we have the highest rates of obesity and chronic disease. But before I share more about these projects, I would like to introduce the people who are in the field doing the work as we speak, and who I am here to represent. Our wonderful and dedicated community health worker team, some of which you see in this picture here, alongside our CDC project officers during our site visit earlier this year. And yes, of course, this is pre-COVID. Nobody's wearing a mask, and we didn't have those restrictions in place yet. Community health workers, sometimes referred to as CHWs, or by the Spanish term promotoras for females and promotores for males, have gone from being someone who is considered a helper to someone who is to a respected profession in the field of public health. If you research the history of community health workers, you will likely run into contradicting dates for the start of our profession. But the truth is that community health workers have been doing the work without being recognized way longer than we actually know. Something we do know for sure is that the community health worker model works best to connect directly into the communities that need the most care. Healthy Neighborhoods currently has a team of 20 community health workers who work on projects ranging from walking school buses to hosting community breastfeeding conversations. And just recently, during the highest peak of the COVID pandemic, CHWs were quickly mobilized to all areas of COVID response. CHWs are professional relationship builders, trusted members of the community, and from my experience of working with so many of them, they are eager to learn and take back important health-related information to the communities where we live and serve. And although we are all aware that there are many moving parts to any successful project, the work that you will hear about next, is largely successful because of our CHW team. Next slide, please. One example of the effectiveness in using CHWs to reach our target populations is seen in the Healthy Corner Store initiative. Next slide, please. This initiative, which focuses on providing corner store owners with the support to sell fresh fruits and vegetables, first started in the south side of San Antonio, Texas, specifically District 3. This was due to the support and advocacy of Councilwoman Rebecca Viagran. Councilwoman Viagran, along with the Food Policy Council of San Antonio, the San Antonio Food Bank, the University of Incarnate Word, local produce vendors, and of course our CHWs, championed this initiative until it came to fruition with our first 8 stores up and running by 2018. What makes our program unique and successful for the communities we serve is that we share the cost of the produce with the store owners. This reduces the risk of them losing money during the first year of the program, while they learn proper storage and handling of fresh produce, while the CHWs get the word out to the community members of where they can buy their fresh fruits and vegetables. But the groundwork for this initiative started years prior, with our CHWs diving deep into the targeted neighborhoods to stir up conversations with residents and corner store owners, where we asked about the types of foods that people in the community already ate, the types of foods that were available at the corner stores, food items customers typically purchased, and even if the store owners were interested in selling healthy, fresh foods. And we also asked residents in those neighborhoods if they even wanted a healthy corner store. Needless to say, the information we gathered during that time gave us the green light to move forward. I skipped ahead on my slide, I apologize. The picture that you saw right before this is Salima. She is the owner of Papa Zip. She is standing in front of her store next to a sandwich board that Healthy Neighborhoods provides, which lets the customer know that this is a participating store. Salima actually had to convince her husband to become a Healthy Corner store, but she's been with our program since 2018, and it's going really well for her. Next slide, please. Here is Mr. Ishmael. Here is Mr. Ishmael, owner of the Highland Food Mart, stocking his Healthy Corner Store fridge, which is also provided to stores that commit to our program. The Highland Food Mart was the first store that I went in to recruit. It actually took me 2 hours of conversation with Mr. Ishmael, where I had to convince him that I wasn't there to scam him, because he could not believe that anyone would offer a program like this. During my visit, I also learned how deeply he cared for his community and how much he wanted to protect them. I actually had to prove that I was from the neighborhood by giving him names of the people that I knew from that area before he even trusted me enough to continue the rest of my talk with him, and which eventually led to him signing on to the program. During my time there, I saw customers come in and out of his store. He greeted all of them with kindness and respect. A young man that came in, who appeared to be in around his late 20s, was carrying a baby in his arms. And Mr. Ishmael shared with me that he had actually met that young man when his dad used to bring him in, and that little boy was just in diapers. And yet he was still there as a loyal customer to his store. To me, this tells me that the programs like the Healthy Corner Store Initiative will benefit the health of future generations to come. The Highland Food Mart is now in their 2nd year of being a healthy corner store that provides fresh fruits and vegetables and other healthy food items to that community. Next slide, please. All 8 corner stores that started with our program have continued, and every owner and their assigned CHW have a story to tell as to how they joined and why they continue on the program. And something we have discovered they all have in common is that they care about the people who live there. Next slide, please. It's because of stories like Mr. Ishmael's and Salima's that interest and funding from other districts has poured in, and we are now in the process of onboarding an additional 12 stores for a total of 20 Healthy Corner stores here in San Antonio, Texas. These stores will not only sell fresh fruits and vegetables, but the community health workers are working to create these stores into community health hubs, where they will organize flu vaccine clinics, nutrition education sessions, blood pressure checks, and other health-related events to provide much-needed services to our community. Next slide, please. Another example where you will see community health workers taking the lead to improve health is at the Pecan Valley Teaching Garden. The Teaching Garden, which was strategically built on the grounds of a WIC clinic by our community partner, Gardopia Gardens, which you see the owner right there in the green, lime green shirt, perfectly complements the existing resources at that location. And having the buy-in from the WIC clinic and leadership will make this project sustainable and impactful by embedding garden-based education into their already robust education plans for families of young children. Next slide, please. With a monthly farmers market already taking place there 6 months out of the year, and with the multitude of services offered by the WIC clinic, it was a natural fit for our community health workers to come in and provide kids activities, health-related topics, conversations with health-related topics, I apologize, and just, sharing more information to attendees about what's available and what's possible in spaces such as these, while also shopping for locally grown produce or simply just to tour the garden and meet their neighbors, which we've had a lot of that as well. People that have not spoken to each other in a long time come to that garden and end up finding out that they have a lot in common. Here you see one of our CHWs teaching kids how to plant before letting them do it on their own. Next slide, please. As you can observe, building spaces like these in communities that otherwise may not have access changes the scenery for the people who live here in the surrounding areas. And every time we invite children into our garden, we feel that it plants a tiny seed of hope in their minds, which can blossom from this experience. We're able to see the kids just really excited about playing in the dirt and planting plants. They feel like they own the garden, and that is really what we want for them. We want them to know that that's their space, and maybe they don't have access to it in their homes, but here it is for them to enjoy. Next slide, please. Community health workers are also a critical piece of the puzzle when connecting community stakeholders to these initiatives. Councilwoman Jada Andrews Sullivan, who joined us at our last event and who is a big supporter of the work that we are doing in the garden and in the community to improve the health of the people in District 2. Just last month, at our grand opening event, participants were invited to take home their very own fruit tree and garden seeds after taking a quick lesson from Stephen Lukey of Gardopia Gardens. Next slide, please. There's Mr. Lukey showing people how to take care of a fruit tree and how to plant it. And the fruit trees in the back there are the ones we had for the people that were attending. People absolutely love fruit trees here in San Antonio, Texas. And it gives the CHWs one more way to connect with these community members. As you can see through some of these photos and some of the stories that I've shared, it's vital that federal funding from programs like the CDC REACH program continue so that we can continue improving the health of the people in the communities across the country. I will close by inviting you to watch a short 3-minute video of the ribbon cutting for our Pecan Valley Teaching Garden. Thank you, and I hope y'all enjoy it.
Tim, you may need to unmute.
We help with planting, with watering, with weeding, all of the things that are helpful for a garden to succeed. In addition to that, other important thing that a garden needs to succeed is community.
Ready?
We let them know that we're going to have community garden work days, and we invite them into this space because this isn't only our garden, but this is the garden for everyone here in the community.
They had the new garden that they started about a month ago. Kids came out and started planting, and we came back to see some of the results. It's good to know that you can have fresh fruits and vegetables in the local area. Especially, we was brought up in the country, so we're used to it. But a lot of people in this neighborhood, especially, is not used to fresh fruits and vegetables.
It's important for us to be here and really throughout San Antonio because of the issues we're having around malnutrition, obesity, and cardiovascular-related diseases. And these food deserts and food swamps, where people just don't have the same access or maybe the same knowledge to be able to lead those healthy lifestyles. So by having a Women in Children's Clinic where the clients can come out here and integrate their programming into the garden is going to be truly amazing and a game changer. And there's not a lot of this happening here in our city, so we're happy that we were able to create a prototype of maybe what should be implemented in years to come.
You know, it's one thing seeing it or hearing about it, but it's another thing being able to really get involved and having them come out here and, you know, helping, you know, with the soil and, you know, planting, so they can see like, okay, we're seeing where this is coming from the, you know, from the gardens in place. So it's really important, and we like that we're here. It was something that we aspired to do, but we just didn't have the funds or the manpower to do it. So the way it started was that Healthy Neighborhoods, they got some grant funds, and it was supposed to be spent for something community-based. And so when this opportunity came about, we jumped on it and we utilized their funds, and now we have a great community garden. And the great thing about it all is that I'm with clients.
Thank you so much, Ms. Gonzalez. Is that it? All right, thank you. That was a really inspiring account of the difference that community health workers are making on the ground in San Antonio, and I think it's a great example to many different communities on working together on this issue. Finally, we're going to hear from Sarah Bleich, the Professor of Public Health Policy at the Harvard T.H. Chan School of Public Health.
Thank you, Dara. You can go ahead and advance the slide, please. So I'm going to talk about national obesity policy trends and give you a sense of obesity projections. Next slide, please. So you heard from Dara and Heidi about what we know about the current problem of obesity, and one thing that's very clear is that weight is very predictable, and so we can look at what the projections are for what's the coming problem when it comes to obesity in the U.S. Next slide, please. So what you're looking at here is a graph showing you the projected prevalence of childhood obesity by race, where on the vertical axis you have obesity prevalence, on the horizontal you have age measured in years, and all those lines are indicating different race groups. And for the key, look in the upper left-hand corner of the slide. So take-home point number one is that overall 2-year-olds today, 57% of them will be obese by the time they turn 35. That's take-home point number one. Take-home point number two is that there are big differences by race. So half of white 2-year-olds today will be obese by the time they're age 35. 2/3 of Black and Hispanic 2-year-olds today will be obese, are expected to be obese by the time they are 35. So there's large growth in obesity, and there are very large disparities. Next slide, please. And we can also look at projected adult obesity by race. And so what you're looking at here, this is using the same data that Heidi presented, but now we're forecasting out in time. And if you start on the top left, you've got maps of whites and then Blacks, Hispanics, and non-Hispanic others. The colors on the maps are showing you different BMI categories, where that brown color is showing you states where severe obesity is the most common BMI category. This is projecting out to 2030. You can think of severe obesity as carrying around about 100 extra pounds. And so take-home point number one from this slide is that the expectation by 2030, which is not 10 years from now, nearly half of all adults in the U.S. are expected to be obese, and that for Black adults, severe obesity is expected to be the most common BMI category. Next slide, please. And so what I want to talk a little bit about is what are some of the policies that are in place now, and what are some policies that might help going down the line when it comes to trying to meaningfully address the problem of obesity. Next slide. So before jumping in to talk broadly about these different safety net programs, I just want to quickly orient folks to the programs that I'll be talking about. And in the Federal Nutrition Safety Net, there's a suite of about 15 programs. I'm only going to talk about the largest ones. And so SNAP is a Supplemental Nutrition Assistance Program. It helps families afford food each month, about 36 million. And that was from 2019. From February to May 2020, there was a 17% increase in SNAP participation, which is 3 times faster than any prior 3-month period in the program's history. And so current participation is at about 43%. The other programs here are National School Lunch, which provides low cost or free meals to children at about 100,000 schools to about 30 million children. WIC, which you've heard about, and In School Breakfast, which provides meals to about 15 million children. So the take-home point here, these are very large programs with tremendous reach. Next slide. And so you've heard a bit about policies that are already working. And so you've heard about the 2009 WIC package changes. And just briefly, WIC is essentially a prescription food program. And what that package change did in 2009 is that it increased fruits, it increased vegetables, whole grains, lower fat milk. And what you heard from Heidi is that as a result of those changes, what the data suggests is that there's been a decline in obesity prevalence among young children ages 2 to 4. So it really shows promise as a major federal program. The second, which Dara also presented, is the change that happened with the Healthy Hunger Free Kids Act, where essentially the latest dietary science got applied to nutrition standards in schools. And what that meant specifically is that schools were required to provide more whole grains, more fruits, more vegetables, skim and low-fat milk, and less saturated fats and sodium. And so if you go to the next slide, what that's showing you is the effect of the Healthy Hunger Free Kids Act prior to the rollbacks happening. And so you've seen this slide once in the past half an hour, but I'm just going to walk you through because these results are pretty striking. It's a study done by Erica Kinney, who's at the Harvard School of Public Health. And on the vertical, you have the predicted probability of obesity. On the bottom, you have time measured in years. And so that blue line is showing you children, the obesity for children who are not in poverty. There's no change there. The orange line is showing you obesity for children who are living in poverty. So if you just track that line across, starting from the left, you can see it goes up. The Healthy Hunger Free Kids Act is implemented in September of 2012, and that line starts going down. What it's telling you is that obesity risk would have been 47% higher in 2018 if the Healthy Hunger Free Kids Act had not been implemented. It also tells you that what that act did is it saved about 500,000 children from having obesity. Next slide, please. So one thing that has happened is that there has been this massive policy shift in response to COVID-19, largely to deal with the issue of food insecurity. And as Dara said, there are strong intersections between food insecurity and obesity. And so if we're tackling one, we might also be tackling the other. And I'm not going to go through all the changes because we just don't have the time for it, but just to highlight some of the major ones. The 2 major stimulus bills that have really affected potentially food insecurity are the Family First Act and the CARES Act, both of which passed back in March. And one of the key things that happened, for example, was that the SNAP benefit, there were emergency benefits passed, emergency SNAP, which said if you're not at the maximum allotment, which is $680 for a family of 4 in a month, you will be brought up to that level for a temporary period. Now, that was a big boost for a lot of families. However, about 40% of families were already at the maximum benefit, and so this did not help them. Another key thing that happened in the CARES Act for SNAP is that about $16 billion got included in anticipation of surges in participation, which, as I've already mentioned, have been happening. And then the Family First Act, about $500 million were included for WIC participation. We've also seen since the start of COVID, there's been a rapid shift toward SNAP Online. So pre-COVID, about 8 states were participating in the pilot. Now it's about 47 states and counting. And there's also been an increase in the number of retailers. And so what this is doing is it's increasing access, and it's helping motivate and promote social distancing. Two other key changes worth highlighting. The first is pandemic EBT, first passed through the Family First Act and then continued for the rest of the school year as a continuing resolution. And essentially what that's doing is it's providing families with children who would otherwise be getting meals at school with some money to cover the cost of those meals. And this program was expanded through the continuing resolution in September to also include children at child care centers. Now, the evidence suggests that PEBT has mitigated hunger for about 3 million children when schools were closed at the beginning of the pandemic. And from every indication, it appears to serve as a reliable food source, particularly when there's low participation in the school meal program. And so, for example, one study from the spring found that over a 9-week period, about 1 billion school meals were missed by children. So access remains a significant issue for feeding children right now. And then the last thing to mention on this slide is universal free meals, which now are going to be in effect for this entire school year. Next slide, please. So as you already heard from Dara, there are lots of other things that need to happen if we really want to change the landscape and both affect obesity and affect childhood, or in general, food insecurity. And so there are 4 here, which I'm going to go through pretty quickly, but happy to talk about them during the Q&A. One is that there has been a large push in the nutrition community to actually expand the overall size of the SNAP benefit. So we've just talked a lot about all these changes that have happened. What they haven't done is take the overall size of the monthly benefit and make it bigger. This is important because the benefit is widely recognized as being inadequate. And so included in both versions, both House versions of the HEROES bill in May and then more recently in October, was a 15% increase in the overall size of the SNAP benefit. It's $100 for a family of 4. And it's a proven policy strategy because back during the Great Recession, during the R stimulus, SNAP was increased by about 14% or $80 per person per month. And that helped address food insecurity. And so the hope is that the next stimulus bill, which is unlikely to happen in the lame duck session, probably more likely in January, the hope is that the next stimulus bill includes this bump for SNAP, even if it's temporary. The second thing, moving to the right listed here, is expanding Medicaid, which Dara mentioned. So 50 states have the ability to implement the Affordable Care Act expansion. At this point, 35 have, 2 are pending, and 13 have not. And expanding Medicaid is obviously a really critical opportunity to expand access to care, but it's also a proven way to help with health outcomes. And what the evidence suggests is that states that did not expand Medicaid have higher rates of obesity than those that don't, suggesting that the expansion may help with obesity prevention. Moving to the bottom left of the slide, right now, as I mentioned, universal school meals are in place for this entire school year. But what happens after the school year? Should we be thinking about whether or not this should be a permanent program? In large part because what the evidence suggests, which you've now seen twice, is that the Healthy Hunger Free Kids Act is protective for low-income children against obesity. And so if it were expanded, could that then be protective for all of our nation's children? And by doing so, help bring down some of those really large costs associated with excess body weight. And then the third area specifically related to WIC is thinking about online benefits. And so just a few weeks ago, there was a pilot that was authorized to sort of begin moving WIC in the online direction. It's in about 5 states. But certainly thinking about expanding that more rapidly, bringing in more states, and allowing benefits to be used online is just like SNAP, so important for access and so important for physical distancing. Next slide, please. And so I do want to, as we talk about policies that are working, I do want to make a point and mention policies that are making it hard to be in the safety net. And these are all specific to SNAP. And there are a number of policies of which I won't go into in detail, which in combination could reduce SNAP participation by about 4 million people. These are in various stages, starting from final rule on the left of the slide, proposed rule, and current policy. And I'll just take a minute and talk about the public charge, because that's gotten a lot of attention in the news. So public charge is a policy proposed by the Trump administration which denies legal immigrants a path to citizenship if they participate in certain federal safety net programs, including SNAP. Now, the Department of Homeland Security first issued this in 2019, and it went into effect in February of this year. There has been significant litigation that is continuing, but the current law is in effect right now. And what seems to be clear is that it is having a chilling effect on participation, meaning that many more people than will be affected by the law are not participating in various safety net programs out of fear that they will lose their ability or their path to citizenship. And so just to be a little bit more concrete about that, it appears that tens of thousands of children fewer are receiving SNAP as a result of public charge. There's one study that found that 1/3 of income-eligible immigrant families with children avoided using public benefits because of the green card concerns. And then it's expected that nearly 700,000 children could lose Medicaid as a result of the public charge. This is expected to be rescinded in the next administration, but certainly something to keep an eye on. Next slide, please. So while I know the focus is largely on federal programs, I think it's important to take a minute and talk about beverage taxes because they represent, from the perspective of obesity, one of the more promising policies that's happening at the local level. So currently in the United States, there are 7 localities that have beverage taxes ranging from 1 to 2 cents per ounce. Some places just tax sugar-sweetened beverages like a Coke, and some places tax sugar and artificially sweetened beverages, so a Coke and a Diet Coke. And what the evidence suggests, and it's growing and quite consistent when it comes to prices, is that if you impose a beverage tax, prices go up. If you impose a beverage tax, there's a consistent drop in volume sales, and it varies by jurisdiction, it varies by retailer type, but it's consistently dropping. In some of the research that we've done among large retailers in Philly, we found a 38% drop in volume sales, which is quite large. And that's equivalent to about 83 million fewer cans of soda being purchased in Philadelphia 1 year after the tax. So a huge public health win. And then in terms of self-reported consumption, the evidence there is more mixed. What we're seeing, though, is no evidence of substitution to sweet snacks, but a little bit of evidence of substitution towards beverage concentrate. So think things like Kool-Aid, for example, and that's just happening in supermarkets. So big picture, beverage taxes appear to be a real policy win from a public health perspective, but then also from a revenue generating perspective. So the 7 localities that have beverage taxes raise about $130 million annually, and that money is going back into communities. So for example, in Philadelphia, it's largely being used to fund child care slots for young children. Next slide, please. Had you asked me 6 or 7 months ago, or maybe a little longer, pre-COVID, so pre-March, if I thought there'd be a national beverage tax, I would have said absolutely not. Now I'm still very pessimistic, but slightly, I think the window of opportunity is slightly more present. And that's because states and local governments are facing enormous resource gaps. And what these numbers here are giving you a sense of is if there were a national penny per ounce tax in the United States, how much revenue would it generate? And that number is about $80 billion. This is research coming out of Tufts. The expectation is that a penny per ounce tax would decrease about cardiovascular disease by about 850,000 cases and diabetes by more than 250,000 cases, and that the net savings, largely from increased productivity and savings in healthcare costs, would be about $53 billion. So having a national beverage tax does have the potential to close big revenue gaps that have been caused by COVID-19. Next slide, please. I think it's important as we think about obesity prevention broadly, not to forget about other areas that are likely to be important in the coming years. So for example, the USDA has allowed states to waive the meal pattern requirements during the COVID-19 period, which means that the nutritional standards have been relaxed and the meals that kids are getting from schools are not the same as what kids were having when we saw those big declines in obesity in those earlier slides that both Dara and I shared. And so there's a possibility that's quite real for accelerated weight gain during this period, and something that we want to keep an eye on and try to get ahead of, because as you already heard, it is much harder to lose weight and it's much easier to keep it off in the first place. Another point, and I won't make every point on this slide that I want to underline, is that from their real heroic efforts of schools in the spring, in the summer, and now in the fall to feed children, a lot of them are facing serious financial burdens. And so it's going to be important in the next stimulus bill to think about shoring up resources for schools that are really trying to feed kids right now. And then as we think about obesity prevention, it's important to also consider the role that the charitable food sector plays. It's relatively small compared to the broader safety net, but it is important, particularly for immigrant populations where policies like public charge are really pushing people out of various safety net programs. And then finally, a point that we should always keep in mind is everything we're talking about is entirely preventable. We shouldn't be dying, so many of us, from diet-related conditions because we can follow healthier diets. we can reduce obesity. We just have to make it happen. And so really getting a sense of urgency around putting the right practices and policies in place to raise up barriers to unhealthy food and to bring down barriers to healthy food is going to be really important, while at the same time promoting physical activity. Next slide, please. And then this is 2 more slides. So I do want to say that as we think back to the federal safety net, it's important to consider all the waivers that are in place right now and how we can learn from them and use them to modernize the program. And so there's a number of things that have happened in the last several months to streamline enrollment, to facilitate participation. And there are many things that shouldn't just go away because COVID does. We can learn from this experience and make it easier to participate in these programs to reduce a lot of the churn that's expensive. It should also be the case that when you enter into the safety net, you are in no wrong door, meaning that no matter how you enter, you are immediately made eligible for all programs for which you qualify from an income perspective. And then looking around the country, how do we scale up the best practices that work? A lot of the work that the CDC is funding, and really bring that up to the national level. Next slide. And so just to wrap up, I think that as we think about the role of nutrition safety net, it plays both a critical role for food insecurity, but also for obesity prevention. But to enhance its ability to help with both of those pillars, we need to enhance the public health impact of the food assistance programs. And that's been an increasing focus over time, but it is not a central focus. And while doing that, at the same time, it's going to be really important to promote equity and to make sure that the groups that are being hit hardest, and we know that right now that's largely Black and brown populations, they are in positions to benefit most from these programs. And then the final point that I'll make is for any of this to be understood, we need continued surveillance to tell the stories of all these policies to understand what works, what doesn't work, and where do we need to make critical changes. Thank you, and I'll stop there.
Thank you so much, Dr. Bleich, and don't be surprised if you see all of this in next year's Ready or Not report. Really great, clear recommendations there. A reminder, I've been seeing many questions in the Q&A, but if you haven't, open the Q&A panel and type your question to all panelists. I'm happy to be joined now by my colleague from TIFA, Daphne Delgado, Senior Government Relations Manager, who will help moderate the Q&A. Daphne?
Thanks. Dara, can you hear me okay?
Yes, we can hear you.
Awesome. So I'm going to ask a few questions while we get the chat populated. We will probably not be able to answer all of the questions, but when we send an email in a few days with links to the webinar materials, the PowerPoint includes contact information for the panelists, so please feel free to ask them questions that aren't answered by the end of the session. This first question is for all of the panelists, and it's really hopefully a timely topic, and that its preliminary research shows that COVID-19 stay-at-home orders have impacted weight-related behaviors such as exercise habits, food stockpiling, stress eating, increases in mental health issues, things like that. Any thoughts on how communities can support healthy habits during COVID?
Should we? Sorry, Dr. Blankenship, why don't you start?
To start, I'll put in the chat, CDC has a webpage on stress and coping, which includes a number of hotlines related to aspects of both mental health and food security. So I will make sure, just as one asset, that's available for individuals here.
Go ahead, Nora, did you have something to say?
Hi. Yeah, I just want to add that, yes, absolutely, that's an issue that's happening. It's an issue that's happening with everybody. But what I see the most is people having information that's not facts. There's a lot of people that are like assuming certain things. They think that they can't go out at all from their homes. A lot of times we get community members who will call the CHWs and say, hey, I haven't been out of my house like in a month. And we're like, why? You could literally go outside. And they're thinking that, even like just stepping outside their door, that they're going to get COVID. So I think just really equipping, community health workers or anybody that's out there educating with the correct information to bring to the families, and just kind of letting them know that it doesn't have to be this way. So I think that's super important.
Great, thank you. My other question is, several leading organizations such as the American Medical Association, American Public Health Association, the American Academy of Pediatrics have released statements and policy positions within the past year stating that racism is a public health threat and that racism leads to real health consequences. Do you have any thoughts on how we can start to change obesity-related systems and programs so that health equity is a priority and not an afterthought?
I can try to take that one, or at least start. So I think that this question is a good one, and it goes back to the point that Heidi was making about that connection between COVID-19 and obesity, where evidence suggests that if a person has obesity and they become infected with COVID-19, they're twice as likely to die. Now, that's factually true, but I think it's important to bridge then and think about, well, why is that happening? And this gets to the point about structural racism. The fact that we're seeing this clustering and constellation of factors amongst low-income and Black and brown populations when it comes to COVID-19 and obesity and unemployment and sort of pick your problem is because of the structures that exist right now. It's not a mistake. And so to answer the question of what do we do, I think that as we think about policies, we have to explicitly focus on social determinants of health that either create inequities or how do we boost them up. So how do we address poverty? How do we address transportation issues? How do we address education issues? How do we use the federal social safety net to boost up people? And how do we target those policies towards the people who are in the highest need?
This is Daria. Nothing to add to that. If you can look at our blueprint for a healthier, for the 2021 administration for a further discussion on this, but you can see the maps of redlining and racist policies of the past and how that impacts obesity rates and chronic disease rates and now COVID outcomes today. So there needs to be an explicit focus on undoing those policies and on boosting affordable housing, healthy housing, and access to transportation, nutrition, those social determinants.
Thanks, Dara. And I will make sure that we also include a link to TIFA's blueprint for the next administration that Dara just mentioned in our follow-up email as well. Nora, specifically for you, someone asked, building community relationships and trust is so important. Were there specific community leaders you engaged with or would to begin building this trust? For example, with your store owner story who needed to believe he was not being scammed.
Yes, the benefit of, being a community health worker is that we are always in the community. I mean, we have that freedom. So it's kind of hard for me to tell somebody to create a relationship when you're in the office. It's very different. So I just think that that's a blessing for us. We're out there. We talk to everybody, okay? We talk to the council person the same way we talk to, somebody who may be homeless. So that's just something that community health workers bring to the table because we see everybody as equal out there, and we're just constantly trying to see what they bring to the table. So, I mean, I don't know that there's like a certain thing that I can tell you about relationship building. It's just more of like listening. Mr. Ishmael really did believe that I was there to scam him. And, but I am from the neighborhood, so it was easy for me to tell him who lives around there and what schools I went to. But people that are not from those neighborhoods and are trying to build those relationships, it's the same thing. You treat people with respect and they give it back to you. And that's really the way I operate. So I don't know if that's helpful or not, but that's what we do. We're professional relationship builders, if that makes any sense.
Makes total sense. Thank you, Nora.
Yes, ma'am.
Dr. Bleich, someone asked a follow-up question. Is there evidence of increased sugary beverage sales outside of the city of Philadelphia?
I think what that question is probably asking is spillover. So are people going outside of Philadelphia to purchase drinks outside because they don't want to pay the tax inside? So assuming I have that right, the answer is yes. But in the case of Philadelphia, that 38%, accounts for the fact that 25% of people went outside. And so there basically was a 25% cross-border shopping effect. People are going outside to buy sugary beverages, but that even after taking that into account, the drop in sales of taxed beverages was 38%. So it's a very significant decline.
Thank you. This is probably for Dr. Blank or Dr. Bleich, but someone asked, what is the role of social workers for this crisis? How do we best serve our clients impacted by obesity? I will take the liberty to maybe just expand that out to different types of community workers in different communities.
Yeah, I was going to say Nora might be able to talk a little bit more about community health workers. I know that in our pediatric weight management programs, where we work in federally qualified health centers and community health centers, that a number of our health professionals are social workers. We're really looking at families that are experiencing a lot of stress, whether that's due to issues around housing, poverty, education. So to jump into a nutrition facts panel on the back of a can is really not an appropriate starting point. It really is to understand what are the family stressors, thinking about sleep routines and ensuring that they've got food in the house. And so much of what we do is really screening for the social determinants of health and really bringing together assets. And so really ensuring that folks who are eligible are obtaining SNAP and WIC, and then blending that with nutrition education to have a healthy lifestyle. So in our pediatric weight management programs, we don't call those obesity programs, but they're lifestyle programs. And really, social workers play such an important role in really being able to dialogue and talk with a family and meet them where they can start.
I can follow up with that. I agree. Just really listening to people, where are they coming from? I mean, the truth is that you can't make anybody do what they don't want to do. But, as somebody who works in the community, I'm always there to listen, and I'm listening for, patterns, things that happen in their childhood. I'm kind of like coming in with a non-judgmental mind of what I want somebody to do. I mean, we all know that it's hard to change. It's hard to change ourselves. So I never go into a situation just, forcing anybody to do anything. I go in there listening and seeing where are the areas that I can help, what areas is that family struggling with? Maybe the mom's a single mom and she's just super overwhelmed. We live in communities where the truth is that there is not a lot of healthy restaurants, especially during this COVID time where everybody was eating out. The truth is it's like here, there's McDonald's, Whataburger, Wendy's. That's the truth. Pizza Hut, that's what we have here. And I can just attest to that. As a mother of 2 boys, I have an older son who's vegan, and I literally do have to drive to another side of town in order to get him his food if we're going to go out to eat. So always just listening to what's happening, where are they coming from, how can I help make your life a little better, but not taking on that responsibility myself of making somebody do what I want them to do. That's what I can add.
Thank you. And I think we have time to hear one more question and answers from all the panelists. My last question is, we've discussed a lot of nutrition-related obesity policies, but obviously obesity is influenced by several other factors, including physical activity. So in your opinion, are there any physical activity-related programs or policies we should be prioritizing or thinking differently on?
Go ahead, Nora.
Thank you. One thing that I see for me, and right now it's hard to talk about this because, the children are not all in school and the whole virtual thing is happening, but really just, revisiting our whole, PE program, what's happening there. Like I mentioned, as a mother of children that are in school, I feel like at this point, PE is used as an incentive to control behavior versus as something that needs to happen. So I think really re-examining the policies in place for physical education in schools. I know, 35 years ago when I was in elementary school, we had physical activity morning, during the day and after school. And now the kids are lucky if they're going out, twice a week. And I don't know why that's happening. Like, I don't understand. So really looking at those policies, I think, is a good start.
Great. And I was just going to add to that. We recently, in September, published licensing report cards for childcare. So this is looking at how states are doing by increasing physical activity policies and practices within their structure. And the good news is we are starting to see physical activity improve across the states. This includes structured time, unstructured time, outdoor time where child care centers or family homes can have this. So I think really, we really want people to have good relationships with food. We want people to enjoy physical activity. We want folks to think about, dancing, gardening, hula hoops, right? We don't want physical activity to be thought about only as having to go to a gym. We know that some people enjoy that, but for a lot of people, they're constrained by their small area. So, so I think really we're finding ways that child care policy has moved forward with greater physical activity. And little kids, right, they're wiggly. We want them to keep being wiggly and bouncing around, really enjoy the physicality of their bodies so that we think about our nutrition, our physical activity, our sleep. We really prioritize the well-being of ourselves.
Nothing more for me to add there, Daphne.
Dara, you want to close it out?
Sure, and I'll just, on the physical activity front, just in personal experience as a parent living in Northern Virginia, you can see when we moved to virtual school, when physical activity was sort of pushed to the side in the spring, when I saw children again this fall, you could see the disparities happening between those kids who had access to a safe outdoor place to play and for those who didn't, and it was along economic and racial and ethnic lines, just in my personal experience. So thinking creatively, I think our schools are doing a better job now that they've figured out virtual schooling and making sure that PE is a central piece of their education, but there needs to be funding so that schools can adapt to do that during COVID and moving forward. Well, I just want to provide a sincere thank you to our panelists for being here today and for their continued work on this issue. I personally want to thank Daphne Delgado, Tim Hughes, Jonah Cunningham from the TIFA staff, and our captionist Jane Conkle from ACS Captioning for making today possible. So we've seen that obesity is a complicated issue and we're not doing enough to protect and improve the lives of those in the United States at risk from obesity. We need bolder policies and more investment in a long-term evidence-based programs that reduce obesity, more collaboration across sectors, continued action to address structural and systemic inequities that undermine health. But I think our panelists also really highlighted several bright spots that I hope inspire you to take action and to communicate with your policymakers about these programs that work and to build across sectors in your community. Our report, which you'll get a link to in our follow-up email, also has several actionable recommendations. So we stand by ready to work with you in these efforts, and we hope this is the beginning of a meaningful dialogue. Thank you again for being here today.